Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General Hospital.
My name is Brett Tavares, and I'm a student intern at the Blum Center this semester.
And before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to hand it over to Brett, who will introduce you all today's guest speaker.
Hi, everyone. So joining us today is Dr. Albert Hung to give us a talk on Parkinson's disease. Dr. Albert Hung is a neurologist and movement disorder specialist at Mass General, a director of the MGH Parkinson's Foundation Center of Excellence, an associate director of the MGH Movement Disorders Division, and an assistant professor of neurology at Harvard Medical School. He specializes in the care of patients with Parkinson's disease, and his research is focused on identifying new therapies for it. Please join me in welcoming Dr. Albert Hung.
So just let me share my video here and make sure that we're good to go. Okay. So Amy and Brett, thanks very much for the invitation to speak today. It's a real pleasure to be able to talk about Parkinson's, and especially this month, which is Parkinson's Awareness Month. Over the course of the next hour or so, we're going to talk about a few different items. I don't have any disclosures that are relevant to the presentation today. So over the next hour, we're going to try to address a few items. We're going to talk a little bit about what Parkinson's disease is, think about what causes Parkinson's disease, and then at the end, we'll talk about some tips for living well with Parkinson's disease. As I mentioned, April is designated as Parkinson's Awareness Month because this was the month that Dr. James Parkinson was born. And the red tulip has come to be a symbol of Parkinson's disease because this particular tulip was developed by a Dutch horticulturalist who had Parkinson's and named this particular species after Dr. Parkinson. It has now been more than 200 years since Parkinson's disease was first described. Dr. James Parkinson was a physician in London, and he wrote an essay based on observation of 6 cases that he saw walking around the streets near him. He wrote the essay on the shaking palsy, and in it, he described what appeared to be common features of these patients. He described involuntary tremulous motion with lessened muscular power in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace. And in this short paragraph, he describes the rest tremor that most people associate with Parkinson's disease, and also the changes in posture and gait that are often associated with PD. Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease. Estimates are that about 1 million people in the United States are affected by PD, and this is probably an underestimate. The typical age of onset for Parkinson's disease is around 60 years, but about 5 to 10% of people will develop what we refer to as young onset Parkinson's disease, meaning that the symptoms begin before the age of 50. Both men and women are affected with about a 3-to-2 ratio. And the incidence of Parkinson's disease increases as people get older, such that by age 65, about 1 in 100 people have Parkinson's. And by the age of 85, estimates are that about 4 to 5% of people have Parkinson's disease. So this is not a rare condition, especially as people get older. There are estimates based on demographics that the number of people living with Parkinson's in the world is likely to double over a period of 25 years from around 2015, when this publication was put out, to 2040. So what we're really dealing with here is really a Parkinson's disease pandemic, where the number of people with Parkinson's is growing, both in the United States and around the world. And it really increases the urgency by which we understand Parkinson's and come up with better treatments. So how do we make a diagnosis of Parkinsonism? Well, Parkinson's disease is still a clinical diagnosis, and many of the observations that Dr. Parkinson made 200 years ago is still what we rely on when we see people in the office. Parkinsonism is characterized by 4 cardinal signs or symptoms: tremor, rigidity or stiffness, slowness of movement, what we refer to as bradykinesia, and changes in walking and balance. Most people identify tremor as the main symptom of Parkinson's. And when people do present with tremor, it's most often a tremor that starts more on one side of the body than the other, and primarily more at rest than with use or with action. You don't have to have tremor to have Parkinson's disease, but the core features that you do need to have are stiffness and slowness of movement. So when we think about the term Parkinsonism, this is really an umbrella term, of which Parkinson's disease is the most common. The majority of people who are diagnosed with Parkinsonism have what we refer to as a primary form of Parkinsonism, or a neurodegenerative condition. And of those, Parkinson's disease is by far the most common. Some people will develop a Parkinsonian syndrome that shares features similar to Parkinson's disease, but has some unique features, both in terms of its clinical presentation and in terms of the way that it responds to treatment. Those are sometimes referred to as Parkinson's plus syndromes, or atypical Parkinsonism, because even though there are some shared clinical features, there are some distinct, unique properties of these syndromes that makes them different from PD. There are also other forms of Parkinsonism that are considered secondary forms of Parkinsonism. Strokes in the right part of the brain can cause a Parkinsonian-like syndrome, what's referred to as vascular Parkinsonism. Repeated head trauma seems to be a risk factor to developing Parkinsonism. Brain infection was something that was seen about a century ago during the Spanish flu epidemic in the early 19-teens. We don't see it so much anymore, but we know from that historical information that certain brain infections can cause a Parkinsonian-like syndrome. And then some patients who are exposed to particular medications, especially psychiatric medications or antipsychotic medications, can develop a drug-induced form of Parkinsonism that clinically can be difficult to distinguish from Parkinson's disease or some of the other neurodegenerative forms of Parkinsonism. As I mentioned, Parkinson's disease is, up to this point, is a clinical diagnosis. There's no specific tests for diagnosing PD. It's not diagnosed on the basis of blood work, and in some cases will obtain brain imaging like an MRI to rule out other causes like small strokes or a condition called normal pressure hydrocephalus, where people have too much fluid in the brain and that can cause a gait issue that looks Parkinsonian. But most of the time, when people have Parkinson's disease, the brain imaging is not going to be informative. And this can be quite unnerving when people come to see a neurologist, because after a period of time where we take a history and do an exam, we tell people that we think it's most likely that you have Parkinson's disease without necessarily doing any confirmatory tests. The definitive diagnosis of Parkinson's disease is ultimately based on pathology, what we see when we look at the brain, and that's obviously not something we do when people are living. When you look under the microscope at somebody who has Parkinson's disease, the main pathologic feature is that a part of the brain that is making dopamine is affected. The first two sections here are cross sections through the middle part of the brain. And the slice on the left shows what a normal brain looks like. You see these two black stripes, and these are part of the brain where neurons or nerve cells that contain dopamine are located. This is the reason why this part of the brain is called substantia nigra, meaning black substance in Latin. If you look at the midbrain of somebody who has Parkinson's disease, you see that these two black stripes are much less apparent. It's because those parts of the brain that normally contain these pigmented neurons have degenerated, and those cells are lost. The biochemical consequence of the degeneration of these substantia nigra neurons is that the brain has less dopamine, and this dopamine deficiency is the biochemical feature that characterizes Parkinson's disease. Now, if you look under the microscope at the substantia nigra, what you will see is you will see some abnormal structures. So in the bottom slide, you see the pigmented neurons. This brown speckling is normal, but some of the brain cells have this pink round inclusion body, which we refer to as Lewy bodies. Lewy bodies contain abnormal protein aggregates that are primarily comprised of a protein called alpha-synuclein. And we'll get back to that more as we're thinking a little bit about the causes of Parkinson's disease. But it's these Lewy bodies that are the pathologic signature of Parkinson's disease. And in order to make a 100% definite diagnosis, this is what a pathologist needs to see when they look at the brain postmortem. That dopamine deficiency has led to the development of some new tests that can help to corroborate a clinical diagnosis of Parkinson's disease. And in particular, there's a special type of scan called a DAT scan. It stands for dopamine transporter scan. With this particular study, the radiologists can infuse a tracer into the bloodstream through an IV that gets into the brain and binds to dopamine transporters on healthy dopamine producing cells. And as a result, if a person has Parkinson's disease and there's loss of those dopamine neurons, you get decreased uptake. If you look at this pictures on the right, what you see is the DAT scan of somebody who does not have Parkinson's disease. And you see these two nice comma-shaped structures, the striatum, which is where dopamine is located. When a person has Parkinson's and those dopamine neurons are lost, you get loss of that signal so that you see what's seen in the bottom picture, where the lower part of the comma is lost. Overall, there's less signal, and there is more of a change on one side of the brain than the other, corresponding to the fact that Parkinson's disease usually at the start is asymmetric, more on one side of the body than the other. This DAT scan can be useful to help differentiate neurodegenerative forms of Parkinsonism, including Parkinson's disease, from other clinical mimics like essential tremor, or people who have a drug-induced form of Parkinsonism or vascular Parkinsonism should have a normal DAT scan. And so this type of study can be useful in certain clinical settings, but it's not a gold standard. Its diagnosis at this point is still based primarily on the clinical findings. So what we understand now about Parkinson's is that it's a gradually progressive condition that is characterized by the loss of dopamine in the brain, specifically in the substantia nigra. What do we know about what causes Parkinson's disease? Well, Parkinson's, like any disease, can be caused by both inherited or environmental factors. There are certain diseases where if you inherit a specific gene mutation, you know you're going to get that disease. Some examples of that are cystic fibrosis or sickle cell anemia, or in the neurology realm, Huntington's disease is a condition like that. If you inherit one copy of an abnormal gene from either your mother or your father, you know you're going to get this disease. There are other diseases that are primarily due to environmental exposures. Smoking, we know now, is a clear risk factor for lung cancer. Or alcoholism, excessive alcohol use can cause liver disease. So in these cases, you can be at risk for developing these conditions, irrespective of what your genetic background is. So what do we know about Parkinson's? For decades now, we have thought that Parkinson's disease is primarily a non-genetic disease. And there's a few pieces of evidence that have led to that idea. The first is one that I already mentioned. After World War I, there was a flu epidemic. And after that epidemic, there were many people who developed a condition that was characterized by slowness, stiffness, what looked clinically like Parkinsonism. And so these patients were diagnosed with post-encephalitic Parkinsonism. And it turns out that the drug that we now use to treat Parkinson's disease, levodopa, was first tested in this clinical setting, post-encephalitic Parkinsonism. And so for those of you who are familiar with the book or the movie Awakenings, this medication was given to large numbers of people who had developed Parkinsonism after the flu epidemic, and it caused them to become much more alive. They were able to move better, they were able to walk in a way they hadn't in decades, and it led to the development of this drug. In 1983, there were a number of cases of acute Parkinsonism which presented to an emergency room in the Bay Area in younger people. It was really unclear what caused that, but through a little bit of investigative work, it was identified that what was shared by all of these patients was that they had used a synthetic form of heroin that had a contaminant in it that caused those dopamine cells to die quickly and caused an acute form of Parkinsonism. It turns out that that identification of MPTP as a toxin that can cause Parkinsonism is still the basis for the animal models that we use in the lab to study Parkinson's disease. One additional piece of evidence to suggest that Parkinson's might not be genetic is looking at twin studies. In these studies, there were large registries of these were veterans, and it looked at both identical and fraternal twins, tried to see whether or not there was any association in terms of their risk of developing Parkinson's. And what was interesting from this study is if you looked at identical and fraternal twins over the age of 50, there was no difference in terms of the likelihood of developing PD. That was different for people who are below the age of 50. It was a small group, but there were 16 pairs of twins that were identified below the age of 50. Of them, 4 of them were identical twins, and they were all affected. So if one twin had it, the other twin also had Parkinson's disease. And among the fraternal twins, the non-identical twins, there was only that pairing in 2 groups. And so this led to the idea that there may be a genetic contributor to Parkinson's disease, but this is only relevant for people who have young onset Parkinson's disease. So if Parkinson's disease is related to environmental triggers, what are some of those risk factors? This is based largely on epidemiology studies and is hard to prove, so that I will say that for the majority of people with Parkinson's disease, we don't identify these risk factors, and we're not able to specifically say what type of exposure might have contributed to the PD. But these larger studies suggest that rural living or well water consumption may be a risk factor. Pesticides does appear to be a significant risk factor for Parkinson's disease, and exposing animals to certain pesticides in the lab can cause them to develop a Parkinsonian syndrome. But exactly what types of pesticides and how much pesticide exposure is required is still something we don't understand. There are certain types of occupational exposures that increase the risk of developing Parkinson's disease. In particular, welders seem to be at higher risk, and this is thought to be related to manganese exposure. And so there's an idea that exposure to certain types of heavy metals might increase the likelihood that a person's going to develop Parkinson's disease in the future. We already talked a little bit about repeated head trauma. And then one of the interesting findings from these large epidemiology studies is that there are some exposures that seem to have a protective effect. Smoking is one of those. Now, obviously, we don't recommend smoking because of all of the negative effects, but there are research studies going on to see whether there are elements of nicotine or other compounds in tobacco containing products that might lower the risk of developing PD. Caffeine is another exposure that may help to lower the risk of Parkinson's disease. We don't usually recommend increased caffeine intake after a person has developed PD, but there's biochemical reasons to think why this might be protective for the brain. So about 25 years ago now, our thinking about what causes Parkinson's disease changed. And that was because there were a number of families with inherited early onset Parkinson's disease that seemed to find that the disorder was passed down from one generation to the next. The first mutation that was identified was in the alpha-synuclein gene. And this was before we knew that Lewy bodies were made of alpha-synuclein. So there were some families where having a single mutation in the alpha-synuclein gene was enough to cause Parkinson's disease. And there were other families which, because of the way that their DNA was passed from one generation to another, had normal copies of alpha-synuclein, but had an extra copy of that gene. And that extra copy, again, caused people to develop Parkinson's disease. And so this idea that you could either have abnormal alpha-synuclein or even just have too much normal alpha-synuclein to cause Parkinson's disease really highlighted this gene and this protein in terms of the way that we think about Parkinson's. Once this gene was identified, you can look to see in the brain where this protein is. And the interest in alpha-synuclein became that much more magnified when it turned out that it's the primary component of these Lewy bodies, which is what we use to pathologically define PD. Once you have reagents that can look for where alpha-synuclein is located, it allows you to do studies to think about how Parkinson's progresses, because you can look at people with very early Parkinson's, more advanced Parkinson's disease, and see how the distribution of alpha-synuclein changes. One of the things that these types of studies show that was extremely interesting is that by the time a person develops abnormal alpha-synuclein deposits in the substantia nigra, it's already located in other parts of the nervous system. So we can find abnormal alpha-synuclein in nerves of the gut, in the lower parts of the brain that control functions independent of movement. It then spreads into the substantia nigra where people develop motor symptoms. And then over time, it can spread to higher parts of the brain, the cortex, and cause other types of symptoms that include cognition and behavioral control. So this has led to the idea that Parkinson's is caused by the gradual spread of abnormal alpha-synuclein deposition through the nervous system, initially starting in parts outside the motor regions and then spreading upward into the brain. The consequence of this idea about alpha-synuclein has led to our understanding that when we make a diagnosis of Parkinson's and are essentially able to see the clinical effects of substantia nigral involvement, there's already a lot of involvement of other brain regions that are below the surface, things that we don't see. Some of these parts of the brain control sleep. So there are some people who will eventually develop Parkinson's who have a condition called REM sleep behavior disorder, where they act out their dreams. And this REM sleep behavior disorder turns out to have a predictive value in terms of identifying who may be at risk for developing Parkinson's in the future. Alpha-synuclein can also involve the olfactory bulb, which affects the way that we smell. And so again, loss of smell can be an early symptom in people who eventually will develop Parkinson's disease. So let's think a little bit about the genetic risk factors for PD. Genetics probably accounts for about 10 to 15% of patients who have Parkinson's disease. There are certain ethnic groups, including Ashkenazi Jewish groups and North African Berber, where there's a higher incidence of genetic PD, so that in these populations, the numbers are maybe up to 40% of people will have an identified genetic risk factor. There are now a variety of genes that have been associated with PD. The two most common are a gene that encodes a protein called glucocerebrosidase, what we refer to as GBA, and another protein, another gene called LRRK2. And where this becomes particularly relevant is that the identification of these genes gives us a target, so that many of the drugs that are currently in development are specifically targeting a GBA or LRRK2 associated with Parkinson's disease. I already mentioned alpha-synuclein. It was identified in those early families, although it is a relatively rare cause of genetic Parkinson's disease. And because of all of the interest in this field now, there's actually a large study that's sponsored by the Parkinson's Foundation called PD Generation, where genetic testing is being offered for these 7 genes, because if we know who has a genetic mutation, it can also identify who might be a candidate for some of these research studies. Now, I had mentioned that up until this point, Parkinson's disease has largely been a clinical diagnosis. There was a really exciting study that actually was just published last week. The study was done as part of a large project called the Parkinson's Progression Markers Initiative, or PPMI, which is sponsored by the Michael J. Fox Foundation. In this study, they analyzed more than 1,000 spinal fluid samples. And what this study did was they took some of the spinal fluid, added a little bit of alpha-synuclein to a tube, along with a fluorescent marker, and basically shook the sample. When you shake abnormal alpha-synuclein, it forms clumps, it forms aggregates, and it can incorporate this fluorescent marker and light up. And so this test is called an alpha-synuclein seed amplification assay. You're using the spinal fluid of somebody who has Parkinson's disease as a seed, and it amplifies these aggregates, and you can measure it. So on the right here, what you see is all of the blue dots are people who had a positive seed amplification assay. The white dots are negative. And so this first one, this first slide shows going from bottom to top along the y-axis, people who have abnormal DAT scans. So if you're lower on the y-axis, you have an abnormal DAT scan. On the x-axis is smell. And so what you see is that almost everybody who had an abnormal DAT scan and decreased sense of smell have a positive alpha-synuclein assay, where others don't. Now, it's quite sensitive and quite specific, but it's not 100%. And so at this point, it's still used for research purposes, and we have to think about how that's going to factor into our clinical diagnosis in the future. One of the things that was really exciting about this study is that if you take people who have LRRK2 or GBA mutations, those mutations that increase the risk, those who had either REM sleep behavior disorder or decreased sense of smell were much more likely to have a positive alpha-synuclein test, even though they didn't have any clinical signs of Parkinson's disease. And so this has led to the idea that we might be able to detect people who are going to be at risk for developing Parkinson's even before they've developed any tremor, stiffness, or motor symptoms. So this has led to this idea of a pathway to Parkinson's disease. A combination of genetic factors and environmental factors different in each person lead to changes in alpha-synuclein that cause it to aggregate into Lewy bodies. The development of those Lewy bodies in the substantia nigra lead to loss of dopamine and dysfunction of the synapses, the connection between nerve cells. And that leads to what is clinically defined as Parkinson's disease. So right now, our definition and our diagnosis of Parkinson's disease is a clinical one. But you could envision that over time, as some of these markers develop, one could say, well, if you have an abnormal alpha-synuclein aggregation assay and an abnormal DAT scan, maybe you've already developed biochemical changes consistent with PD, even though you don't meet that clinical diagnosis yet. The greatest need in the treatment of Parkinson's disease is to find treatments that will slow down PD. And despite a lot of research and despite a lot of advances in the way that we understand Parkinson's, there are still no currently proven disease-modifying treatments for Parkinson's disease. And all the treatments that we have are used to treat and improve symptoms. Now, this is an optimistic time because there are a lot of different treatments that are currently in clinical trials or in development. We're not there yet, but hopefully we'll be there in the coming years. Now, some of the challenges. The animal models that we have are not ideal in terms of mimicking what happens in people. Because the disease progresses slowly over years and decades, it's hard to find treatments that are going to slow it down because you have to follow people for that period of time before you're going to be able to detect change. And as I already mentioned, the lack of biomarkers has been difficult and slowed down the way we identify people who might be at risk for Parkinson's even before they develop clinical symptoms. This alpha-synuclein assay may be a step towards that, but at this point, it's not yet a quantitative assay, so we'll have to see how things play out. I'm going to spend the rest of the time now talking a little bit about how to live well with Parkinson's disease. There are a few things that people should know. The first is that treatments are available for the motor symptoms of PD. Even though we don't have treatments to slow it down, there are medications that can be very effective in terms of reducing the symptoms and improving quality of life. This is a list of some of the currently available medications for Parkinson's disease. And the important thing to know is that there's not just one, there are multiple classes of medications, but the majority of them work to help the brain make more dopamine. The most effective medication to treat Parkinson's symptoms is levodopa. This was the drug that was developed 50 or 60 years ago and was tried on those patients who had post-encephalitic Parkinsonism. Levodopa is the direct precursor to dopamine. So when you take this in a pill form, it gets into your bloodstream, gets into the brain, helps the brain make more dopamine. And it's the most effective drug for treating Parkinsonian symptoms. Levodopa is given with another medication called carbidopa, and it's this combination, carbidopa and levodopa, when given together, that most people refer to as Sinemet. And the reason why it has that name, Sinemet in Latin means without emesis or without vomiting. If people took levodopa alone, everybody would get sick and queasy and nauseous. By giving it by carbidopa with it, it helps the levodopa work better and helps to minimize the side effects if you were to take that drug alone. For most people with Parkinson's disease, starting levodopa really can help to improve the symptoms. And the goal is to use medicines like levodopa and other treatments to keep the symptoms under control. Over time, and by time I mean years, people may still respond well to the medication, but find that it's not quite as effective. And that's because of the way levodopa works. So when you take a dose of levodopa, it gets into your bloodstream very quickly, but within a few hours, most of that medication is gone. When the levodopa gets into the brain and made into dopamine, it can stay around longer. And so even though it may be gone from the bloodstream, a person can still feel the clinical benefits of the levodopa in terms of improving their overall mobility. Over time, as the capacity of the brain to reuse levodopa goes down, people find that they're more dependent on the timing of the medicine. And so when you take a dose of medicine, it works for a while, but by the end of the dose, or if your dose is late, you notice that the medication is wearing off. When a person takes the next dose, it then may take a little bit of time for the medication to get in and become active. And you start to notice these fluctuations where you might feel on for a while, meaning that your medicine's working, and then when the medicine wears off, then you feel off. Over time, higher doses of medication that you need to treat symptoms can also sometimes cause excessive or involuntary movements, which are referred to as dyskinesias. So if any of you have seen Michael J. Fox recently, you find that oftentimes he seems to be writhing or moving around a little bit. Those are his dyskinesias. And these are the consequence of needing higher doses of medicine to treat Parkinson's symptoms adequately, but because of the ups and downs and the fluctuations, these dyskinesias can emerge. So if these types of fluctuations develop, the first step working with your neurologist is to try to adjust the medicines to try and reduce these fluctuations, both the ups and the downs. In those cases where the management of the medication is more difficult, people may benefit from deep brain stimulation or DBS surgery. This is a procedure where electrodes are put into the brain. They're wired under the skin to a pacemaker-like device, and essentially the way that you could think about DBS is like a pacemaker for the brain. And the reason why DBS is effective is because it can electrically change or modify the circuit that's responsible for the Parkinson's symptoms in a way that does not require so much medication. And so people who have typical Parkinson's disease who responds well to medications, but where they're developing motor fluctuations or side effects related to treatment, may be a good candidate for DBS surgery. Usually, when a person has a stimulator put in, it allows you to reduce the dose of medicine, and so you can reduce the side effects, including dyskinesias or other adverse effects from taking too much dopamine medication. For people who have atypical Parkinsonism or a Parkinson's plus syndrome, DBS is not indicated. Now that's a little counterintuitive because one would think, well, if you don't respond that well to medicine, which is the case for most people with atypical Parkinsonism, why not surgery? It turns out that surgery is primarily useful in terms of treating the same symptoms that levodopa treats. And for people who have significant cognitive issues or dementia, or where mood is a major issue, DBS is relatively contraindicated because sometimes the surgery and the stimulator can make those types of symptoms worse. So in addition to knowing that treatments are available for the motor symptoms, it's important to recognize that non-motor symptoms are very common in Parkinson's disease. I showed you this slide already to highlight the fact that the pathology of Parkinson's disease extends beyond the substantia nigra. And because the pathology involves other parts of the nervous system, you can get other types of symptoms. This is a nice slide showing some of the other symptoms that are common in people with Parkinson's disease. And if you read around lightheadedness, memory problems, back pain, decreased libido, change in urination, constipation, weight loss, weight gain, slurred speech, drooling, dry skin, sadness, depression, changes in sleep. What's shared by all of those symptoms that I just mentioned is that they're non-motor symptoms. They don't directly involve movement, and they don't necessarily respond to medicines that increase dopamine. Non-motor symptoms can happen throughout the course of Parkinson's disease. There are some symptoms that I already mentioned that are what we call premotor symptoms. Depression and anxiety oftentimes precede development of tremor or motor symptoms by years. Constipation, loss of smell, this REM sleep behavior disorder that we discussed earlier, these are common symptoms for people who may eventually develop clinical signs of Parkinson's disease. Now, REM sleep behavior disorder is fairly specific. The other symptoms, depression, constipation, loss of smell, are not. Lots of people will have these symptoms who will never develop Parkinson's disease, but they do inform the way that we think about how Parkinson's starts and progresses. People who develop Parkinson's disease are also at greater risk for developing later non-motor symptoms, including cognitive impairment, psychosis, or hallucinations. They may develop autonomic problems with constipation or urinary symptoms, or what we refer to as orthostatic hypotension, when the blood pressure fluctuates and drops when you stand up. And so we have to think a little bit about monitoring these symptoms as Parkinson's is diagnosed and develops. And so some of the keys to develop or dealing with these non-motor symptoms, first is recognize them yourself if you or a family member or friend have Parkinson's. Acknowledge when they affect your quality of life. Bring them to your doctor's attention. they're not as visible. It's not the same when a neurologist is looking for your tremor as when your neurologist is trying to identify if you have constipation or a sleep disorder. And so when these symptoms are bothersome, it's important to let your doctor or neurologist know, because in many cases, they're treatable if the symptoms are bothersome. Another important lesson to know when you are living with Parkinson's is the importance of developing a regular program of exercise. Now, it's not surprising that if you are experiencing changes in your mobility, that exercise might help. And we do know that exercise improves many aspects of motor function, not only the stiffness and the slowness, but it can also improve gait and balance, symptoms which may not necessarily respond as well to dopamine medicines. But what's really important about exercise is that exercise might also have some neuroprotective effects for the brain. If you take animal models of Parkinson's disease, force them to exercise, and look to see what happens to those dopamine neurons when they're given a stressor or a toxin, exercise protects those nerve cells. And so it's led to this idea that exercise might not only have some positive effects for mobility, but it actually might slow down disease progression, including motor symptoms and cognitive impairment. Exercise can also help non-motor symptoms of Parkinson's, including sleep. And so there are current guidelines out now that have been put out by the Parkinson's Foundation that recommend that people do 150 minutes, 2.5 hours of moderate to vigorous exercise a week. And people ask me, well, what type of exercise should I do? My usual recommendation is find something that you enjoy doing. I think a good mode of exercise is something that combines some aerobic exercise, whether that is walking, running, biking, whatever it might be, along with exercises that work on flexibility and balance and strength. And but the most important thing is that you develop a program of exercise that you can keep up with. There's nothing harder to do than exercise if it's not something that you enjoy. So another important key to living well with Parkinson's is to know that resources are available. I will say that many people, when I diagnose Parkinson's disease, feel very alone. You know, they've been living with these symptoms maybe for months or maybe years. Maybe they haven't necessarily shared it with all their family members, and they feel when they're given this diagnosis, they don't know what to do. So you want to work with your doctor, work with your neurologist, try and figure out ways to improve your quality of life as much as you can, but know that it's not just you and your doctor working together. Our approach at Mass General and Brigham and Women's is that we really think about dealing with Parkinson's disease as a multidisciplinary program. And so even though the person with Parkinson's and their family, their neurologist, their primary care doctor are at the core, majority of people with Parkinson's disease will benefit from seeing a physical therapist or an occupational therapist or a speech therapist. If you're experiencing significant anxiety or mood issues related to Parkinson's, you might benefit from meeting with a social worker or a psychologist or psychiatrist. And then in some cases, there might be a role for a genetic counselor, or there might be a role for a sleep specialist or a GI specialist, or where DBS is necessary, including a neurosurgeon. So when we're dealing with Parkinson's, our goal is to make sure that people have access to these resources so that we can really help to try and manage the symptoms in the very best way possible. There's also a lot of online resources for Parkinson's disease. And, there's always risks of going online and trying to figure out more about Parkinson's or whatever condition you might have. You want to make sure you go to the right places and get the right information. The Parkinson's Foundation, it has a great resource, a lot of education programs for people who are living with Parkinson's, including those who were recently diagnosed. There's also a number of other foundations, the American Parkinson's Disease Association, which has excellent information, not only about Parkinson's, but about some of the support groups that are located in Boston and New England. And the Michael J. Fox Foundation really has spearheaded much of the advances in research over the last few decades. And so for those people who are interested in finding out more about what's going on in Parkinson's research, the Fox Foundation website is a good place to go. So what the last point I want to make is that for people who are living with Parkinson's disease, the other thing that we and my colleagues at Mass General or other academic centers recommend is to think about participating in research. There's not a person that I know who doesn't hope that our research in Parkinson's progresses more quickly, and we can find better treatments, we can find ways to slow down Parkinson's. But it turns out that clinical research in Parkinson's is not so easy. I think that we all agree that the more we know about Parkinson's, the better we'll be able to treat it. But it turns out that every treatment in development required human volunteers in order to be able to get to that point. So levodopa, other medications, deep brain stimulation, all of the treatments we currently have would not be available if people hadn't volunteered to participate in the study. Sometimes when you choose to participate in a research study, you might have an opportunity to get a new potentially effective drug or treatment years before it is FDA approved. Ultimately, the reason why I encourage people to participate in research is really altruistic. You know, participation will help others with Parkinson's in the future. It may help a family member, a friend, somebody else that you know. It will help millions of people in the future from each clinical research study that people choose to participate in. I think the important thing to know is that 30% of all clinical trials fail to recruit a single person, even though all of these are based on good science. And 85% of clinical trials face significant delays because of limited participation. What's interesting is that fewer than 10% of people with Parkinson's disease ever take part in any research trials, even though they are overwhelmingly interested in working with researchers and scientists to help speed treatment breakthroughs. And so I think as a person who lives with Parkinson's, you really want to work with your doctors, work with physical therapists to help yourself feel the best that you can. That's really what I try to do as a Parkinson's specialist, is help people achieve the highest quality of life that they can despite having PD. But to recognize that if you are interested in participating in research, you can actually feed that forward to the many millions of people who develop PD in the future. So just to summarize what we talked about today, Parkinson's disease is a gradually progressive condition with both motor and non-motor symptoms. PD is caused by a combination of genetic and environmental factors that has a different interplay for each person. Although we don't have available treatments yet to slow down Parkinson's disease, there are effective treatments available to improve the symptoms of PD. Exercise is a key part of managing Parkinson's, both because it helps improve mobility, but it can also improve non-motor symptoms. And based on what we know from research studies, it might have some benefits in terms of slowing down the overall progression of the disease. And ultimately, the advice I give is focus on living your best life. You know, our goal is always to use the treatments that we can to help people do their very, very best despite a Parkinson's diagnosis. Thank you very much for your attention. I'm glad to have a chance to speak with you, especially during Parkinson's Awareness Month, and I'm happy to take any questions.
Thank you so much, Dr. Hung. We are now at the end of the session, so if you have any questions for Dr. Hung, feel free to enter them in the chat. We have a two-part question regarding MSA. Is MSA considered a Parkinson plus condition? Additionally, for those who have MSA, how can you, do you have any comments on how responsive they are to Parkinson medications?
MSA is a condition that's called multiple system atrophy. And multiple system atrophy is what we think of as a Parkinson's plus or an atypical form of Parkinsonism. It shares some pathologic features to Parkinson's in that it also has abnormal aggregates of alpha-synuclein, but they're located in different brain cells. In general, patients with multiple system atrophy don't respond as well to Parkinson's medicine. And one of the defining features of MSA is that they are much more likely to have problems with the autonomic nervous system, control of blood pressure, control of bladder, bowel, sexual function. And so sometimes when you try and use Parkinson's medicines, they're not tolerated as well in MSA patients because it can cause their blood pressure to drop.
Thank you. What percentage of patients end up with Lewy body dementia?
That is a really good question. And I think it highlights some of the shortcomings of the way we think and refer to some of the Parkinsonian conditions. So I think what the question refers to is, what is the likelihood of developing cognitive impairment in the setting of Parkinson's disease? And just to give you a little bit more information, the term dementia with Lewy bodies is a very similar but separate condition where people develop early cognitive changes in the context of their Parkinsonism, along with other neuropsychiatric symptoms, including hallucinations. People who have typical Parkinson's disease over the course of years and decades may develop cognitive issues, and we call that Parkinson's disease dementia. So Parkinson's disease dementia and dementia with Lewy bodies together constitute a sort of, again, an umbrella term called the Lewy body diseases. There is a higher incidence of developing cognitive change in the context of Parkinson's disease. It's hard to know the specific numbers because over time, as people get older, there are other causes of dementia as well. Alzheimer's is much more common than Parkinson's disease. And so as people get older and develop cognitive changes, it's hard to know for sure how much of it is explained by Parkinson's disease alone, how much of it may be something else, whether it's Alzheimer's dementia or vascular dementia related to strokes.
Thank you. Does having a reduced sense of smell since childhood indicate any potential risk for Parkinson's disease, or is a sudden loss of smell a more indicative characteristic of Parkinson's?
It's a great question, and it's something that I think there's a lot of interest in understanding. I would say that if a person has had a reduced sense of smell ever since childhood, the likelihood is less that it's related to Parkinson's disease. Also, I would say that if it's very sudden, that might also be less indicative of Parkinson's. I would say that the sort of time frame I would think where loss of smell, or what we've referred to as hyposmia, might be a risk factor is gradual loss without another explained reason. So sometimes people lose smell because they've got a lot of sinus disease, or sometimes head trauma can cause a loss of smell. So in the absence of another factor to explain it, having a reduced sense of smell that gradually comes on, maybe during middle age, might be a risk factor. But again, I think there's still work to be done on how predictive that will be that a person develops PD in the future.
Are symptoms typically slower to develop for early onset patients?
So there is a lot of interest in terms of thinking about how Parkinson's progresses for different people. And in the first slide, when I mentioned the symptoms of Parkinson's, tremor, stiffness, slowness, it turns out that different types of people who are diagnosed with Parkinson's may have different types of symptoms. Some people present with a tremor early on without a lot of other symptoms. Those patients will sometimes refer to as tremor-dominant Parkinson's disease. And there is some data to suggest that tremor-dominant Parkinson's disease may progress more slowly than people who have a lot of stiffness or slowness, or especially gait or balance problems at the start. In general, patients who have young onset Parkinson's disease also progress more slowly. But at the same time, our goal for those people is to manage their symptoms for a much longer period of time. If a person develops symptoms in, say, at the age of 50, we want to think together about how do you manage those symptoms until they are 80, 90, where somebody who develops their symptoms in their late 70s or late 80s, the way we approach treatment might be slightly different.
Thank you. Have you seen an increase in Parkinson's for those who had COVID, particularly patients with lost sense of smell?
That is a really great question, and it's one that we don't know the answer to. So there are two interesting things that you point out. One is that early loss of smell is often associated with COVID as a sign of viral infection. The other piece of information is one that I alluded to, which is that there are certain viruses that can cause a form of Parkinsonism. And so when COVID started 3 years ago, there was a number of studies that came out asking a question of whether or not a person could develop Parkinson's disease, or at least a Parkinsonian syndrome, as a consequence of COVID, given some of the shared pathways in terms of involvement of the olfactory neurons and the way that we think about Parkinson's spreading. I don't think we know the answer to that question yet. I think this is basically a work in progress. I think over the next 5, 10, 20 years, we will know more. And it may be that one of the questions that we ask is, did you have COVID? Now, this is tough because almost everybody is getting COVID now. And maybe it turns out if you had COVID pre-vaccine or a more severe form of COVID, would that be a risk factor? I don't think we know the answer to that question.
Thank you. Do you have any thoughts you can share regarding high dose of vitamin B1 treatment for Parkinson's?
So B1 is thiamine, and thiamine is very important for the functioning of the nervous system, as are other vitamins. There have been a number of studies looking to see whether any particular supplements can help improve symptoms of Parkinson's disease. The short answer is no. So for people who have, say, low B12 levels or low vitamin D levels, it's good to take supplements, but there have never been any studies suggesting that high kind of super therapeutic doses of any of these vitamins have a direct effect on Parkinson's disease.
Thank you. I think we have time for one more question. Is the treatment for young onset Parkinson's different from the onset of someone diagnosed at an older age?
That is a really good question, and we could spend another hour talking about that. So I didn't have time to talk about some of the nuances in terms of the treatment of Parkinson's disease. I think that there are a variety of different medicines that are available to treat Parkinson's. Levodopa is really the gold standard. There's a separate class of medicines that are called dopamine agonists that substitute for dopamine in the brain. And in some cases, in people who have a young onset Parkinson's disease, there might be a role for trying a medicine like a dopamine agonist before starting levodopa. There's risks and benefits to it. It's not a question I can answer here, but it's a really good question because as a neurologist, these are some of the things that I think about when I'm encountering a new patient with Parkinson's.
Thank you so much for an incredibly helpful presentation today. Before we end today's session, Dr. Hung, are there any final thoughts you'd like to share with the audience?
No, I really appreciate the opportunity to meet with all of you. And, it's great to have programs like the Blum Center. I think that to me, having education is really a key. As people are living with a variety of different medical conditions, the more you understand about the condition, the more motivated you are to feel the best that you can. I think the better off you'll be.
Thank you so much. And for everyone who took the time to join us today, thank you so much for joining us. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. So if you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. And once on the home page, click on the tab that says News and Events. From there, there's a section titled Past Blum Center Programs, and the recording will be made available through there. All right, well, thank you so much, everyone. Have a lovely rest of the day.